We then realized that it may not be a good idea and not possible to go to different places and do the programs every time. So we started with the e-learning, starting off with the free YouTube videos. And there are over 400 videos which are available freely in that perspective. And these videos basically are accessible to across the globe. And a lot of people have been accessing these videos over this time. And as we are looking at currently, there are a lot of people who are subscribing even to this program as well. So there are over 1.5 million views which have been given in these videos in terms of this e-learning program. We then realized that we needed to have a structured program rather than just having some videos. So we started off first with a fellowship program from 2017. And till date in the Regency Center of Diabetes Endocrinology and Research, we have had 11 fellows who have been involved. And I remember Dr. Kapoor, when we went for the first time, and he said that, yes, we should start the program. It was one of the few centers which started the program at that point of time. So in the last 7 years, continuously, we have got very good fellows and with good support from the hospital. In 2018, we started the online learning portal MedEClasses, and then a lot of books and application came up. So we have got pediatric endocrine learning tools. We have got fellowship programs in pediatric endocrinology, a 2-year course. And many of the people who are here actually are part of that course. They are coming 4 times in a 2-year period to gain experience, clinical, as well as learning in that perspective. We have developed the MedEClasses endocrinology app, which I was talking about. It's the most downloaded pediatric endocrinology app with over 5,000 installs, a lot of publications coming onto it. We are working in terms of developing connected clinics, which will help out people develop personalized care in terms of specific disorders. So we have developed tools to guide evaluation for growth failure, which have been validated. There are tools for management of diabetic ketoacidosis, which have been shown to reduce the complications of DKA. We have developed a bone age application, which provides within 2 minutes a reliable and valid way to assess bone age, which has already been published. A lot of other interpreters are there, which are being published, include our obesity interpreter, our puberty interpreter, as well as thyroid interpreter. So these interpreters are going to make life very easy. You have to enter the values and you will get the right outcome. And they have been validated in a large number of patients in that perspective. We also developed a DSD interpreter. And the next step, which Vibha was talking about, was the bone age assisted interpretation of growth, in which all the pediatricians have to do is to enter some basic information with regards to the child in terms of their age, in terms of their birth weight and other parameters. And then you have to enter about their pubertal status. And then you can either have a manual entry of bone age, or you can have a data which you have to select the sites and get the right data in terms of bone age. Now, this bone age assisted interpretation of growth is a tool we have been using and validating for the last 1 year in our center. And this has been found to be perfect in terms of not only plotting the data, but also getting a lot of interpretation and whether our puberty and growth is going normal or not. So this is going to be probably a way in which we can really screen a large number of normal children, as well as patients who are coming to different pediatricians in terms of school, as well as clinic, to get the right guidance in terms of evaluation and management from that regards. So we've got different courses. We have on-site course. So we have had 7 on-site courses till now. And yesterday we had a big number of around 48 participants from across the world actually, and over 300 patients who had come from different parts of the country to specifically come and get exposed in this perspective. We have got multiple publications, and we have now coming up today with the 2nd edition of MedEClasses Basic Pediatric Endocrinology.
So this case, term neonate born out of non-vaginal delivery, non-consanguineous marriage, cried immediately after birth, and the birth weight was 2.4 kg. The child was admitted for neonatal hyperbilirubinemia in NICU for 3-4 days. And at day 20 of life, the child had fever and the child was worked up at periphery. And what they found a persistent hyperglycemia. So they started regular insulin. Okay, and initially the child was diagnosed as late onset neonatal sepsis and IV antibiotic was started. But since the hyperglycemia was persisting, the child was referred at 40 days to our center. And we admitted that child, and as per the guideline of neonatal diabetes, the random blood sugar was more than 200 milligram per deciliter for more than 3 days. So we made, and the blood ketone was lower side. It was not in DKA. So we made the diagnosis of neonatal diabetes, not in DKA. And we started basal insulin in form of injection glargine. We started with this 0.2 unit per kg per day. And gradually, we will see in the subsequent slide how do we escalate the treatment and how we shift to other modalities. Then SOS, the insulin list probe was also started whenever the child needed the blood sugar spike went up to more than 200, 250 milligram. The challenge with managing neonatal diabetes is that the child had frequent fits, initial days, 2 hourly or 1 hourly, and you cannot give bolus to every fit. And the quantity required in terms of insulin is very low for these children. So the guideline is to give bolus whenever the random blood sugar is more than 250 milligram per deciliter. And glycemic control, we were lucky enough that we managed to bring the blood sugar down to less than 250 milligram per deciliter. And the next step is naturally the confirmation of the diagnosis. So C-peptide in this case was towards lower side. Glycated hemoglobin was 5.8%. And for etiological workup, to rule out any renal problem, pancreatic agenesis, we did the CT abdomen, which was normal, and then we sent genetic test. So genetic test showed heterozygous mutation in ABCC8, and there was this novel mutation which was not there in the database. So to highlight this, the problem was with the potassium channel. And as we all know that whenever there is problem with potassium channel, we have to shift from insulin to sulfonylurea drugs. So we started with glibenclamide, 0.2 milligram per kg per day, and gradually we built it up. So the dose, adult dose is very low, 0.07 milligram per kg, and in neonate, it is rather high. So we went up to 0.8 milligram per kg per day, and gradually we tapered down the insulin, and we could taper it down. And since the child presented at 40 days, we tapered it down and we could stop insulin. And at 4 months of the child, what we have seen in follow that the requirement of glibenclamide was very low. Almost it was negligible. So I discussed with sir, and we had planned that why don't you stop it and see how the child behaves. So we stopped it. We stopped glibenclamide and we closely followed the child. We did all the milestones. We seen all the milestones, neurological, this assessment, growth, etc. And at 9 months of this age of the child, the C-peptide was still lower side. And then what we have seen that the blood sugar was fluctuating around 250 milligram per deciliter. Glycated hemoglobin was at that time towards normal. But during gradual follow-up, what we have seen that C-peptide was not rising up. And blood sugar was fluctuating between 230, 270, 280. And now this glycated hemoglobin was started rising up. So again, I discussed with sir, then we had a discussion that it is behaving like permanent form of neonatal diabetes. So we should start this glibenclamide again. So again, I started this glibenclamide 0.1 milligram per kg per day. And I revised the diagnosis as permanent neonatal diabetes mellitus. Since you remember the child presented at 20 days of life. So we see that those children who present early, they usually turn out to be transient form. So we thought that this is transient. But since the child behaved like this, ultimately we made the diagnosis of permanent neonatal diabetes. The growth parameters were normal, luckily. So differential diagnosis initially we kept like stress hyperglycemia, severe sepsis, congenital infection, etc. But that was ruled out, and ultimately it was neonatal diabetes mellitus. So what we see that this child neonatal diabetes, usually these children are low birth weight. So our child was also 2.4 kg, and mostly this potassium channel problems, they usually present this less than 1 month, more than around 30% of cases, but they can also present between 1 and 6 months, more of the 2/3 cases. And there was a large cohort of this where they found that most of the potassium channel are associated with neurodevelopmental disorder also. But luckily, here the Dent syndrome is associated. But what we see in our case, it was okay. It was not affected. The child was neurologically okay. Our mutation was this a heterozygous mutation, where at the position 262, the asparaginase was changed with tyrosine, but the report was this uncertain significance. With this case, what I want to highlight that many times you have to judge and you have to see clinically. Maybe the mutation is novel, which has not still been there in the database. So it can come as uncertain significance. Although it was showing that the ABCC mutation is associated with permanent or transient neonatal diabetes. So to go further in research, at many research centers, they do functional study to prove it, that this novel mutation is causing that clinical or phenotypic variation or not. So they do functional study, which we could not do. So neonatal diabetes, as I said, is if you have a child having persistent hypoglycemia, which is more than 200 milligram per deciliter for more than 3 days. Usually when you doubt, it is better to admit the child and see the trend. So if it is if it is more than 200 for more than 3 days, you put it as neonatal diabetes. And the first thing is to send genetic test to prove, because if it is potassium channel defect, it responds to sulfonylurea. The incidence varies with the place to place. Western countries, in India, it is around 400,000, but the places where consanguineous marriages are more, like in Middle East countries, it is quite common. It is almost around 21,000 to 25,000. In pediatric diabetes, the prevalence of the neonatal diabetes is 1 in 400. The onset usually less than 6 months, 85% are usually monogenic. But if the onset is between 6 to 12 months, the monogenic forms are usually 55%. Okay, so what we see here, in Western countries, the proportion. So what we see, this transient form, which is more in Western countries, it is less in India, but permanent, it is more in India. And so this is just to highlight that mostly the transient neonatal diabetes 1 are mostly because of this 6q24 imprinting defect, while permanent forms are usually sulfonylurea responsive drugs, this neonatal diabetes like KCNJ11 mutation or ABCC8 mutation, and isolated other defects like this insulin gene defect, glucokinase defect, or HNF1 beta, or this GLUT2 defect. Type 2 are mostly this KCNJ11, ABCC8, syndromic are mainly permanent, like APEX syndrome, Volcker-Trellison, or Roger syndrome. Now, this is very, very much important. How do you, if you found that potassium channel defect is there, you have started insulin. Now, how you are going to shift it to sulfonylurea? This becomes very, very important, and it should always be protocolized. So always admit the patient. Don't treat these patients on OPD basis, because it will be very difficult to monitor glucose and build up glibenclamide. So after confirmation of mutation, you have to start oral hypoglycemic drugs. So use, as I said, you start with 0.1 milligram per kg and build it up. So usually the transition is done over 7 to 10 days, depending upon how the child is behaving. So you have to start oral hypoglycemic drug and taper the insulin. Here I beg your pardon that first the basal bolus, first basal one is stopped. So when you start glibenclamide, on day one, you give the bolus basal, which was you were giving. On next day, you give it like 0.1 you have given today, 0.1 BD. Next day, you give 0.2 milligram per kg BD and stopped basal and give bolus as you were giving. So this depends on pre-meal blood sugar. If your pre-meal blood sugar is more than 200, you continue the same dose of this bolus insulin. But if it is less than 200 milligram blood sugar, reduce the dose of insulin by 50%. On next day, again, you increase the dose of glibenclamide, and same has to be followed. And ultimately, you have to stop bolus also and switch over. You have to switch over the child completely on glibenclamide. And meanwhile, you can also see the rise in C-peptide. But mind you, many times you have to have this glucagon injection at hand. But during glibenclamide switchover, it was seen that there was no reported cases of hypoglycemia on glibenclamide. Mostly the side effects are GI side effects, which are not worrisome. Diarrhea, vomiting, sometimes rashes has been reported, but those were not dangerous one. Okay, so thank you very much. My take-home message will be always do genetic test, always admit those children, prove the diagnosis first. Whenever you are switching it from insulin to glibenclamide, always do it inpatient, and sometimes transient to permanent is confusing one. So thank you very much.
Thanks a lot, Dr. Pradeep, for this wonderful talk.
So any questions from the audience? I am having one question, that how frequently you can use the boluses in a day, and what is the dose you decided? Bolus insulin.
So bolus, as per, since there is no, you cannot calculate carbohydrate here. So it is said that 0.01 unit per kg you can give, and that has to be diluted in the diluted preparation has to be given.
The newborn, usually you give many feeds. So at that time, how you decide about those bolus therapy?
So that I said, sir, you have to calculate, you have to take the pre-meal sugar. If it is more than 250, then you have to give. It is less than 250, you have to omit. You don't have to give bolus.
I think that's a very important message. And the other message is that everybody whom you're labeling transient has a risk of developing recurrence of diabetes, be it in the childhood or infancy or even in puberty, as we saw the similar genetic case presenting to us later on.